Your name الله يرضى عليك اسمك زميلكم Khalid. طيب شكرا Khalid. Khalid, yesterday actually it was a good catch when you asked me about the need for adjustment of the dose of the clarithromycin. The slide was right. Your note was actually excellent. That's a good follow-up. Yani. So the slide was absolutely right yesterday. We need to adjust, though it's hepatic eliminated, but at severe renal impairment, a patient at very low GFRs, we need to adjust the clarithromycin for sake of the metabolites. Okay, so the slide is right. Shukran, Khalid. Now, so today we're going to continue with the variable groups that inhibit the protein synthesis in the bacteria. We're going to start with the lincosamides presented with clindamycin, then followed with the oxazolidine nons, which is presented by linezolid. Then we're going to pass through chloramphenicol and ending with the quinapristine, dalfopristine. Now, again, just a refreshment for yesterday illustrations for the how the protein gets synthesized in the prokaryotic bacteria, and this illustration actually shows how the start of the protein assembly by assembling the amino acids forming the peptides, and here we can see clearly that the tRNA bring that's the tRNA and bring the amino acids and enter through the A site. Then it moves according to the codon, and that gets read by the anticodon. Then it moves to the P site till we get a peptide formed. So I think this illustration is better than those presented yesterday. Maybe it would help anyone who was still, didn't get the real picture, or the picture was not very crystal clear for him. This slide actually presents how, or the different mechanisms of the various antimicrobials that exert the inhibition of the protein synthesis. And we can see how the mannose cause a distortion of the messenger RNA, and that causes the production of faulty or erroneously read erroneous read messenger RNA. So that will lead to the formation of erroneously amino acids and faulty peptides. Now let's move to the lincosamides. The lincosamides actually includes two antimicrobials. And both of them actually they are extracted from the streptomyces, again similar to the mannose and vancomycin. So the streptomyces is a good bacteria. It's a subclass from the actinomyces, and this form of bacteria actually provides us with many antimicrobials in reality. It's found in the different types of soil. The most clinically used lincosamide is clindamycin, and most of the hospitals actually carries clindamycin, not the lincosamide. Now, similar to the macrolides, lincosamides exert a bacteriostatic activity. They interfere with the synthesis of proteins at the 50 subunits. So their antibacterial is exerted by inhibiting the enzyme, the peptidyl transferase reaction, and that's located on the 50 subunit of the bacterial ribosome. So, and because of this, actually, the share between the macrolides and the lincosamides, at the same enzyme, so you might suspect that patients who develop resistance to macrolides, they might also develop resistance to clindamycin. Okay. Okay, so back to the slide. So from your understanding, which step does the clindamycin inhibit? Is it the initiation, elongation, or the termination? Elongation, yes, excellent. Also, clindamycin exerts some sort of immunomodulatory effects in addition to its antimicrobial, so that's a good advantage. So if usually or mostly when you have an infection, you need to recruit the immune cells, like the white blood cells, for example, to help in fighting the infection. So clindamycin exerts similar like chemostaxis. It exerts chemostaxis. You know what's chemostaxis? Okay. Anyone? It's a process of tracking. Yes, it's a process of sending messengers through the body to recruit the lymphocytes and the other set of the white blood cells. Yeah, so that's the chemostaxis. So clindamycin help in the process of the chemostaxis. Besides, also another advantage of clindamycin, usually when you go to clinical practice, inshallah, you will be seeing clindamycin added to a broad spectrum antimicrobial. So sometimes you say, okay, I assume this patient on meropenem or imipenem. Why clindamycin is added? It doesn't provide any synergistic effect, and they share the same coverage. But the issue is clindamycin is added to tackle the toxins of the bacteria, to reduce the release of toxins. And many infections, actually, they are exaggerated by the release of different toxins from the Staphylococcus aureus and from the Streptococcus pyogenes. So we have, especially when we fight necrotizing fasciitis, which is actually inflammation of the soft tissues and the deep layers of the skin, and it's an infection with really bad complex sequels. So the infection actually starts not from above, as you see it usually with cellulitis. It starts from down. It's kept unnoticed. Then it invades the whole skin, and the skin will be totally slumped. And this actually patients who develop this infection mostly is because of the gram-positive cocci. An important bacterial enzymes that get reduced by clindamycin is the DNase enzyme released by the strep. What do you think? What's the DNase? It breaks down. The DNA, yes. Excellent. And also the streptolysin O. Also, there's another enzyme that gets inhibited by clindamycin. So the good thing, when you add clindamycin to an antimicrobial regimen, the levels of the DNase will be decreased within 48 hours. It will be almost zero. So that is a very appealing advantage of clindamycin. Now let's go to the spectrum of activity of clindamycin. It covers most of the gram-positive, including MRSA. So this is a good advantage in patients who actually develop MRSA, and the MRSA was sensitive to clindamycin. You could release a patient who received, for example, vancomycin in hospital, then the patient could be discharged on clindamycin. Or if the patient had an infection that it required no admission to the hospital, but it was the bug that was isolated, was MRSA, clindamycin will be a good choice on those patients. In addition, it covers some of the Corynebacterium diphtheria, the diphtheroids. It is a gram-positive roads. Mostly they are found on the skin. And this bacteria actually caused the Corynebacterium sebaceae, for example, one of the infectious agents that increase or exaggerate the development of acne. So clindamycin could be used to treat acne, similar to what we had a medication yesterday that also could be used in treatment of acne. Doxycycline, yes, doxycycline. Now, also, it has a good anaerobic bacterial coverage. So we have gram-positive and anti-anaerobic coverage. It covers the Bacteroides, and also covers the Fusobacterium and the Provitilla species. So as soon as an agent that covers the Bacteroides, which is actually the the most abundant anaerobes in the colon. So that will lead, what to suspect that will develop if we eradicated the normal flora that's presented as the bacteroides. Yes, C. diff. So clindamycin is flagged the #1 agent in its ability to provoke the development of C. diff. So it's not, many clinicians actually, they don't feel comfortable in prescribing clindamycin in hospitalized patients. Also, in addition to its antibacterial activity, it covers many of the protozoa, like the Pneumocystis carinii and Toxoplasma gonadi. So the Toxoplasma, you know, which animal carry the Toxoplasma mostly? Cats, yes. It is the infection that get acquired from cats. So the treatment of the toxoplasmosis is clindamycin, one of the options that could be offered to the patients. And most of those actually bacteria infect the immunosuppressed patients. You mostly see this bacteria in patients with AIDS. Notably, that with all of this coverage of clindamycin, clindamycin has zero coverage for the gram-negative bacteria. So it doesn't cover any gram-negative aerobes. I'm talking about the aerobes. Now, it could be used to treat dental infection, because many of the dental infections actually, they are in the oropharynx, cover staph, and also if there was a deep abscess in the gum, that will be containing also anaerobic bacteria. So clindamycin could be an ideal treatment for dental abscess. Also, it could be used for treatment of aspiration pneumonia. Someone, especially after a patient or who come to the emergency, or who swallowed lots of water, like from drowning at a swimming pool or in the sea, clindamycin would be a good option when it's get combined with a beta-lactam, like cefuroxime. Also, it's a very effective medication to treat cellulitis and necrotizing fasciitis. Because its ability to penetrate well to the bone, so also clindamycin is a good choice for treatment of bone infections. Because actually bone infections mostly they are caused by Staphylococcus aureus. So clindamycin has a good activity against that. Topical applications could be used for treatment of acne because its ability to eradicate the Campylobacter species. And again, that we just talked about the ability to reduce the toxins. This is for treatment. Now, yes, please.
Clindamycin is for mild or moderate acne.
Well, not severe. Acne never gets severe, but you know, mostly it's more we say complicated and uncomplicated. Maybe the phrase I use is not better. So for complicated acne, yes, maybe doxycycline would be a better option. Clindamycin maybe get for the uncomplicated type of acne. For the prophylaxis, now clindamycin is among the options for surgical prophylaxis for patients who are going for different types of surgery. If the patient had an allergy to beta-lactam, the patient cannot receive any of the cephalosporins to treat or to prevent an infection in surgical patients. Also, it could be used in the prophylaxis for endocarditis, and that's what we mean for dental procedure. That's what we mean by endocarditis prophylaxis for patients who had an allergy and they cannot receive amoxicillin for tooth extraction or for deep dental procedures. Now, among the features of clindamycin that we need to bring it on surface here is it's undergo the hepato or biliary recirculation. You know what is the anterior hepatic circulation that's called how physiologically the bile. We don't lose much of bile actually in our stool because most of the bile gas it gets after it's secreted, it will be reabsorbed back. So it will be preserved. Now, clindamycin, because actually it's a biliary secreted medication or hepatically eliminated, so it undergo also a anterior hepatic circulation. So, and this could be advantage that it would give the patient a prolonged activity to eradicate the bacteria, And on the other hand, it might get the patient prone or susceptible to C. diff because this is long in the duration of the clindamycin therapy. So it is metabolized by liver, and that's mean there is no need to adjust in patients with hemodialysis, and we need to adjust the dose or maybe to select another agent when we are treating patients with liver cirrhosis. This medication is absorbed, fairly absorbed and administered orally, and it's available in IV and oral form. And we could switch the patient to equivalent dose from the IV to oral. This is one of the advantages also could be offered by clindamycin. Although with all of this image of clindamycin of being highly penetrating medication, unfortunately, it doesn't penetrate to the CSF. It will be blocked by the blood-brain barrier. Also, it could be used safely in pregnant females. So that's another advantage to be offered as in surgical prophylaxis. Especially in patients, pregnant female who actually go for C-section or other procedures. So the pregnant females might be offered clindamycin without any precautions. Now, I think we spoke about the C. diff extensively. So the most important thing that you need to know that clindamycin is ranked #1 medication in its ability to provoke the development of Clostridium difficile infections and the release of the toxin. Most of the toxic megacolon, which is actually presented here, it means that the colon, with this massive amount of toxin gets released, it will paralyze totally the smooth muscles in the colon and render it inactive, and so that will make the colon flaccid, totally dilated, large in size. If you view it in the CT scan, and with this flaccid colon, it will, with the fully loaded of bacteria, it will act as a source of contaminating the whole body. So immediately, toxic megacolon it's an indication for surgical resection of the colon if it was touched earlier. Okay, so always need to apply caution when you gonna prescribe clindamycin for a patient. Other suspected complications is development of jaundice because this medication gets accumulating in the liver, so it might increase the bilirubin and the alkaline phosphatase. Also, they might increase the ALT and AST in the form of steatosis. Now, which are the other group that might also induce C. diff? Now, we have clindamycin ranked #1, and we have 2 other groups. We had at least one of them that they are claimed or they have been blamed for the development of C. diff. Cephalosporins, yes. Okay, so we have rank #1, clindamycin, followed by rank #2, cephalosporins and the quinolones. And you're gonna get your lectures for quinolones soon. I don't know, someone of our colleagues will be rendering that. So the moxifloxacin, especially moxi, is among the agents that are really associated, it's used associated with the development of Clostridium difficile infections. Now let's move to the oxazolidine diones. It's a new group actually of medications. It was the linezolide is the prototype of this group, and it was approved after the millennium. Other agents called tidozolide. I want you all to know linezolide. That's what we request from you here. Linezolide is known to be one of the gram-positive agents. What other previously we had gram-positive agents like? If we're going to ask you about, give me or name 3 agents that they are a gram-positive agent, purely gram-positive agents. We have linezolide, it's one of them. No. Even Pseudomonas. Yes, vancomycin. So we have vancomycin. Now this is second, and sorry. It covers the gram positive, yes, like clindamycin, and also with anaerobes, okay. But with a broad spectrum that covers most of the gram positive. So we have linezolid, we have vancomycin, clindamycin, but more important, the other glycopeptide, يا جماعة. No, the other glycopeptide. Teicoplanin, yes. Teicoplanin, yes. Okay. So those are they exert an excellent anti-gram positive activity. Okay. So we have teicoplanin. Right. Now, linezolid covers even the MRSA, fairly cover of MRSA. It covers even the VREs, the vancomycin resistant enterococci. It covered the pneumococci, all the species of pneumococci, or even those resistant to ceftriaxone and vancomycin. And against Streptococcus species, it exerts bactericidal. Known that linezolid is bacteriostatic generally, but it exerts some has bactericidal activity against the strips. Also, it covers the anaerobes, but it's not very reliable agent when it comes to treatment of anaerobic bacteria, and covers also the Corynebacterium, similar to clindamycin. But again, we only use clinically, we only rely on the use of linezolid to treat gram-positive cocci. And similar, it covers the Mycobacterium tuberculosis, similar to which agents also they are antimicrobials, and they could cover their activity extend to cover the Mycobacterium. So we have now linezolid and yes, aminoglycosides. Yes, they are the most they could be used, especially streptomycin could be used to treat tuberculosis. So if does it cover Pseudomonas? Does linezolid cover Pseudomonas? No, yes, because it's only purely gram-positive agent. Okay, so it doesn't cover the gram-negative. Now, the linezolid actually it acts in a totally different path compared to other protein inhibitors. Now, even it inhibits actually it could be labeled as an agent that halts the initiation process of the protein synthesis, but actually its activity is different from just binding to the A site. It's act even far earlier than that. Actually, you know that it prevents the assembly because each unit actually is separated before the process of the bacteria when it starts inside the protein. So the ribosome will be assembled from the 50 subunit and the 30 subunit. Now, what will happen with the linezolid? It will inhibit this process. So because actually there we have the we call it the initiation complex, which consists of the 30 subunit and initiator RNA, what we call the mit RNA, and the mature messenger RNA, and initiation factors. The initiation factors actually they are the proteins or enzymes that act to bring all of these components of the 70 subunits to be assembled together. So the linezolid will inhibit this process. So the 70 subunit will not be assembled. So it acts very earlier in the process of the initiation. Now the linezolid actually it binds to to the 23S RNA. You know the ribosome actually, as yesterday we had the large illustration that showed that the ribosome actually consists from a folded RNAs besides some sort of proteins. One of those RNAs, we have different RNAs actually in this ribosome, like the 5S and the 23S, and in the 30S you have the 16S RNA. So specifically, the linezolid will bind to the 23S, and that also will inhibit the ability of the 50 subunit to bind with the 30 subunit. So, and that's why the development of resistance to linezolid, because this mechanism of activity it's very hard for bacteria to undertake two steps in resistance, although it's coming. There are reports of staff developing resistance, but still at low scale. Now, so it's combined with the 23S and inhibit the process of assembling the 50S ribosome. Now, because of the linezolide compete with the chloramphenicol and lincosamide for binding for the 50 subunits, theoretically, it might be clindamycin when it's added to linezolide, it might attenuate its activity, but actually this never tested clinically because actually it's very difficult to add clindamycin to therapy in a patient who's receiving linezolide. Also, it doesn't inhibit the peptide transferase like chloramphenicol and lincosamide. So on the other hand, so it's only about the compete only actually on the site where they bind. Again, that's regarding the resistance issue that's frequently encountered. So generally, we could say that the linezolide actually is an agent that inhibits protein synthesis at the level of the initiation process. Now, we cannot use linezolide alone to treat polymicrobial infections because polymicrobial, like intra-abdominal infections, usually they are polymicrobial, including the gram-negative and the gram-positive of the gut. So either to be combined, or we cannot use it solo agent. It's approved by the FDA for the following infections to treat hospital-acquired pneumonia. So in combination with an agent that covers the gram-negative, can anyone give me a regimen of antimicrobial to treat hospital-acquired pneumonia using linezolide? We have a patient, hospitalized patient, and I want to use linezolide according to the FDA recommendation to be combined with an agent that covers the gram-negative, right? So anyone can name any agent, please? Okay, name it. Name a specific name of application. So as Suriname with linezolide, it's one of the combinations. So it's not the ideal combination because actually as Suriname doesn't cover the envelopes there. Okay, but it is a good combination. It's not wrong. So what is other combinations? Imipenem, yes. So imipenem combined with linezolide is an excellent option to treat hospitalized patients who develop hospital-acquired pneumonia. Yes, please. No, because meningococcus by coverage, you're right. But usually, a meningococcus, it's because of nephrotoxicity and ototoxicity. We don't provide them as a first line cure in all infections. Okay, okay. So we have one of the carbapenems. We have no one mentioned tazocine at all. No tazocine, no the piperacillin tazobactam. No one mentioned that at all. Right. So we have imipenem, cilastatin combined with vancomycin. We have piperacillin tazobactam combined with linezolide or vancomycin. So you have an option to switch between linezolide or vancomycin when you start empirically. The aim of that is to cover the MRSA, and I'm sure that I'm covering pseudomonas, because those are the hospital commensals that they are probable, and I need to cover them till I get culture showing that this patient's growing something that doesn't merit this broad spectrum of antimicrobials. Also, they could treat all the infections caused by VRE, vancomycin-resistant infections, and also could be used to treat complicated and uncomplicated skin and skin structures without a concomitant osteomyelitis. Also, they could be used to treat community-acquired pneumonia because this agent is available in oral form, by the way. It's available in IV, injectable form, and in oral form. Now, let's go to the complications of linezolide. With all of these advantages, linezolide still it carries some sort of problems with its use. Now, initially, when a patient receives linezolid for only two weeks or less, most of the complications actually they are associated with its ability to provoke nausea and vomiting. Now, the problems start when the linezolid therapy continues beyond 2 weeks. Now, the patient might be predisposed to serotonin wave. Serotonin wave, that's because actually the linezolid blocks the MAO. It's one of the MAO inhibitors, the monooxidase inhibitor. So it will inhibit the enzyme that destroy many of the neurotransmitters that like the serotonin, like the dopamine. So their level will go high. Okay, so the patient might go to a serotonin wave represented as hypertension. Suddenly the patient is not unknown to be hypertensive. The patient will go to high blood pressure, tachycardia. The patient will be sweating, diaphoresis, and some patient might go to a phase of agitation.
Can the patient also present with locked jaw?
Sorry?
With locked jaw.
No, it's very unlikely. Then also another important complication is the development of lactic acidosis, such as high lactate in the bloodstream, and that could be fatal. The patient might go to severe tachypnea, and by this might affect at the level it affects the whole body by affecting the Krebs cycle and the formation of high amount of lactate. It also linezolid inhibits the bone marrow, and that could present it as the incidence of development of thrombocytopenia exceeds 7%. In patients who receive linezolid for more than 2 weeks. Then, unfortunately, most of these situations, if it develops, it will it's reversible generally. Now the problem, if the patient receives linezolid for more than 4 weeks, here's a problem. The patient might go to irreversible neuropathy. And this could be at any small nerves in the body could be affected. And that's like, for example, the patient might go to optic nerve damage, and the patient might end with blindness. When actually, initially, most of the neuropathy develop at the extremities. So at the hand, the patient might feel some coldness, inability, or weakness in the hands or the lower extremities. And that might also lead to tingling pain or shooting or some burning sensation at the end of the nerve. Similar to how the diabetics, patient with uncontrolled diabetes, how they feel. It's the same actually complicated sensation. And here's a problem: if a patient who actually the patient was diabetic and was treated with linezolid, and the patient actually will not maybe he or she might be complaining from these complications or from diabetic, and she or he assume that it's an extension of his problem with diabetes, but on the other hand, it might be the linezolid and will be kept unknown. Especially again, because this patient, this medication is available in oral form, so many patients could be discharged on oral or receive it as an outpatient. So always the patient who receive linezolid for more than 2 weeks, you need to monitor the CBC. Or every week need to look to the CBC. So because we need thrombocytopenia actually might precede all this, many of the symptoms that before it progress to neuropathy and etc. Yes.
Is the serotonin syndrome and the neuropathy?
No, the serotonin is actually because it inhibits the enzyme that break down the serotonin. Okay, so we come to discuss this also as well. Now, again, because the linezolid actually has one of the important features that it has an excellent bioavailability. It's available in IV and oral form, and it's the absorption of linezolid is almost 100%. So it's highly bioavailable medication. So you could switch the patient immediately to oral and with a reliable or trustable outcomes. It achieved very high levels in the lungs. and even in the bronchial secretions. Unlike, that's the slide, but we skip the vancomycin. Okay, so there's a good chance that we again refresh you that vancomycin actually concentration in the lung it's around only reach 40% of its serum levels. So always when we have a patient with with pneumonia and with patient with vancomycin, we need to shoot up the levels of the vancomycin from 15 to 20 milligrams per liter, just to push the vancomycin to the lung bronchial and the bronchial secretion. Now, linezolid, on the other hand, might achieve four times higher level than could be achieved by vancomycin. This is a good advantage of using linezolid. But the other hand, as again, clinicians might not be very comfortable with this image of the adverse effect linked to the use of linezolid. It penetrates well to the CSF, and actually linezolid penetrates well in all the tissues. And it's metabolized by the liver by oxidization, and there's no need to adjust renal failure. So patients who are at high risk for renal impairment, patient, let's say at CKD, or the patient has any risk of renal impairment, and the patient needs gram-positive activity, the patient might be offered linezolid without monitoring and without need to adjust the dose, unlike the glycopeptides. Now, those are the drug interactions. Now, linezolid, it doesn't affect the P450 cytochrome. So the nature of the drug interactions, they're far away from the cytochrome enzyme. Now, this is the enzyme, this is the monoamine oxidase inhibitor. And that's explained why how it maintains or keep the serotonin unbroken, so or unmetabolized. So the serotonin level and other neurotransmitters like the dopamine will be elevated. Even at the level is like norepinephrine might be not also breaking down because some of the norepinephrine will be broken by the amine oxidase. So that will keep the patient in high sympathetic surge, and that the patient might manifest with this symptoms that we just discussed a while ago: tachycardia, epilepsy, high blood pressure, could be secondary to the use of linezolid. Also, patients who are receiving linezolid should be instructed not to eat the yellow sheets. The yellow sheet is rich in the tryptophan. You know what's tryptophan? It's one of the amino acids, so it's a base for the serotonin and the dopamine. So to not allow the body to synthesize more of the serotonin and dopamine. Also, it's patients need to be counseled about the use of the smoked and pickled smoked beef, like the beef and turkey, like chicken, and exactly, and also other agents that also act on the serotonin pathway, like the tramadol, one of the analgesics. Patients should not use tramadol with linezolid, it's totally contraindicated. Also, patients using SSRIs to treat depression. So these actually all the SSRIs generally are contraindicated. I'm just bringing those two as an example for you. So sertraline or paroxetine should not be used in patients who are receiving linezolid. Or if a patient maintains on those agents, better to avoid linezolid and pick up another agent that covers the ground positive. Also in the ICU, then I observed that patients who admitted the ICU, and many of those patients receiving actually pressors, the pressors that need the epinephrine, the norepinephrine, the dopamine, the patient will get very sensitized to the use of the pressors, maybe even requiring lower dose as compared to the patients who are not maintained on linezolid. So always, as clinicians, especially the intensivists, we need to apply caution when using or starting linezolid. Just forget about the silicoline. No one is using silicoline. It's one of the antipsychotic agents, old antipsychotic agents. Just forget about that. Now let's move to the chloramphenicol. Chloramphenicol, actually, I'm practicing as a clinician since more than 12 years. I never saw a patient actually using chloramphenicol. It's one of the medications that's almost abandoned. In the United States, they stopped manufacturing oral chlorphenicol since 1998. It was stopped, I mean, from the oral form. Now it's only in hospitals you're going to find it as on the side for patients who develop like a resistant microorganism, and there is no option to use, so it might be offered to those patients. It was discovered by Venezuela by streptomyces, the soil also in 1947. Till we were able to extract the molecule. That was 2 years after that. It's a bacteriostatic agent, and it covers actually it's broad spectrum antimicrobial. It covers the Staphylococcus aureus and exerts a bactericidal activity against Strep pneumoniae, so Haemophilus influenza, and that's why the old days it was indicated to treat meningitis. So when we talk about more than 30 or 40 years back, it's among the agents that treat meningitis, and up to now, in some certain poor countries, you're going to find chlorphenicol used up to now in to treat meningitis. Like sub-Saharan countries, in India, they're still using chlorphenicol to treat meningitis. Also, it covers the enterococcal, and it covers the anaerobic bacteria, and besides the atypical bacteria. So it covers many bacteria. It's really very appealing, but it's complications that we're going to discuss in the coming minutes. It has no activity against Pseudomonas aeruginosa. معلش الصوت ده ورا انا ما قولوا لي معلش انا نضطر نروح هناك. Okay, so it inhibits the bacterial ribosome by inhibiting the 50S ribosomal peptidyl transferase and prevents the peptide elongation. So this is similar to which agents? Macrolides and okay, and this orange fish memory. Just clindamycin. We just discussed a while. Okay, fine. Okay. Okay, so it's also as the same. So all of these agents actually they inhibit the process of the elongation of the proteins. Chlorphenicol also inhibits the mitochondrial protein synthesis in the mammalian cells, and actually perhaps that's because the it exerts activity against the mitochondrial ribosome. Any one of you interested and read about the mitochondria? This is a side information. You know, mitochondria is one of the organelles, right? Anyone had any interest to read about the mitochondria? How it's the house power in our cells, right? Even in the plant cells. Yes. Yes, exactly. Yes. So there is one of the theories that it might be a bacteria. It might be an ancient bacteria that was engulfed by another bacteria, and then they had this mutual benefits. I mean, and that's why, because the mitochondria, you're going to find two layers, actually, two membranes surrounding the mitochondria. So, and it has its own protein synthesis path. It's multiplied. But so maybe one of the theories says yes, it's and that's why maybe because the mitochondria share the same antibacterial and also human ribosome. So that's why maybe chlorphenicol actually hits the mitochondria, and all of the adverse effect that we are seeing with chlorphenicol come from this. From this idea of inhibiting the mitochondrial ribosome. I forgot to mention that also linezolide, by the way, one of the suspected mechanism of inhibition of the thrombocytes by inhibiting the bone marrow, and because of inhibiting the mitochondria as well. That also applies for linezolide. Okay. It's available in oral and IV form, and also because it's highly toxic, it needs a therapeutic drug monitoring. So now we have how many agents now you had that they require a TDM? Okay, we have now chlorphenicol, and we have vancomycin, and amycretin. Yes, that's good. So we have 3 agents that require a TDM. actually, and that's mostly these agents. I don't think other agents that you would be exposed to in your next lectures, I believe. Yes, I think that's the agent that among the antibacterial that need TDM. Nowadays, you're going to see some chloramphenicol marketed now to treat some conjunctivitis. So inflammation in the bacterial inflammation of the eyes. That's what you can find it now used clinically. Now the problem of the chloramphenicol, its ability to induce aplastic anemia. It is rare complication, but when it develops, it's a fatal complication. It's irreversible suppression of the bone marrow. If there's no identified risk factor, though some genetic predisposition might be suggested, and actually can occur after weeks from treatment, even after stopping the chloramphenicol. And this is really problematic. The patient might receive the medication, and the patient will be discharged, and then after a couple of weeks, the patient come with a picture of aplastic anemia, and maybe the patient will be seeking treatment for a different clinic, different hospital, without noticing that the patient received chloramphenicol. So always, any patient who receive chloramphenicol need to be followed with a complete count of the blood cells, yes, CBC. It penetrates well to the different tissues, and that's why we use it in meningitis, because its ability to pass the blood-brain barrier. And it's also a potent inhibitor for the cytochrome 2C19 and 3A4. Now, it interacts with which medications? Can you name any medications that it could interact with the 3A4? Orthamycin, yes. Orthamycin is from the antimicrobials, yes. Yes, not that much, but yes, orthamycin. Well, there are macrolides. Yes. Yes, excellent. That's among the azole antifungal. Generally, all the azoles, yes, all the azoles. And among the other medications, non-antibacterial, like what we have, at least you exposed to two at least. Cyclosporin and the anticoagulant rivaroxaban or warfarin. So this actually interacts with these agents. Now, when it's given for neonates, it can cause a known syndrome as gray baby syndrome. You're also going to find this question in many of the exams, actually, in advanced medical exams. So as to which medication can cause this drastic complication. Again, we spoke about some neonates because they have this immature liver function, and because chloramphenicol is particularly eliminated. So without a good functioning liver or mature liver, so the chloramphenicol will start to accumulate, and that will cause the gray baby syndrome, where it's actually it interferes with the myocardial respiration process or the oxidative phosphorylation. If you remember your biochemistry, so where the muscles of the cardiac muscles actually depend heavily on this path of respiration, because it's not anaerobic or not aerobic respiration, both type of respiration. So the patient will go in a cyanotic phase because the myocardium is not able to support blood. So, and that will give the baby this cyanotic or the gray appearing features. Definitely, it's contraindicated for use in pregnant females. Now let's go to the third and the last group of agents that inhibit the protein. We call them the streptogramine antibiotics. This group, actually, this medication is not marketed in the kingdom here, but you're going to find it in North America. Actually, the quinaprostine and dapaprostine is a combination of two agents that inhibit the protein synthesis. They are actually directed against the treatment of MRSA. And initially, they were marketed as an agent that to overcome the bacteria that develop resistance against vancomycin, which is the VRP. So they are effective against this combination, effective against the VRP. It also covers some gram-negative bacteria like the Moraxella catarrh, Legionella, and Neisseria species. The Neisseria is a gram-negative. Cocci, yes, it's not rolled. Huh? Okay. One of the capsulated bacteria, by the way. And it cannot be used to treat any of among the Enterobacteriaceae group, except for the Moraxella catarrh. Okay, for Pseudomonas, the coliform antimicrobes, like which again the coliform microbes, E. coli and Klebsiella pneumoniae. That's among the Enterobacter coliaci. Okay, some proteus species. Okay, or these are what we call the coliform species, and they're not covered by pristine, pristine. Or it covers many of the anaerobic bacteria like Bacteroides fragilis, Clostridium perfringens, and Clostridium difficile. So would this agent provoke the development of C. diff? No, because it covers the C. diff. Okay. Actually, those agents actually they are also again started from the Streptomyces. So this bacteria actually provides us with plenty of antimicrobials. Now, the most important in pharmacological aspect of this combination that they actually represent how the synergistic effect shows. Now, they are synergistic to each other, though both of them actually acts on this as a protein inhibitor. So this is not from different groups, but how could we translate the synergistic into numbers this way? Now, if we're going to use, let's just take a VRE, vancomycin resistant enterococci. The MIC of the VRE for when we're going to use it for dalfopristin, for example, it's 32. When we're going to use it with quinaprisin, it's 500. That's very high resistance. Now, if we're going to combine both agents, the MIC will be dropping to 0.5 microgram per ml. So that's how the synergistic effect.
Is it 0.5 microgram of each combined?
Which one? No, combined. Both of them. We use them combined. That's the effect, yes.
0.5 micrograms of like quinaprisin plus 0.5.
Yeah, you know how they do the MIC?
Yeah.
They install actually a drop of the antimicrobial itself. So in the last one, they install the combination, the two agents together, the testing. So let's hold up. Oh, sorry, shukran. So again, just to repeat for sake of the voice. So this could be this combination represents well the synergistic activity of the antibiotics. Now, like quinapristine, like the MIC for dalfopristin is 32 microgram per ml. Now, when we use quinapristine, the quinapristine is around 500. Now, the combination of the two agents will be dropping to 0.5 microgram per ml. So this is really big drop, and that reflects how the synergistic effect could be translated in numbers. Now, this combination actually comes in a ratio of 30% of quinapristine and 70% of dalfopristin. They're available only in injectable form, and they are hepatically eliminated medications. So there's no need to adjust in patients who are receiving hemodialysis. Among the complications of this combination, mostly there are infusion-related adverse effects, like inflammation in 40% of the patients. That are really high incidence, and that's why actually many hospitals didn't add this combination to their formulary, because actually it's very problematic when it comes to the nurses and to the patients when the patients actually develop infusion-related complications. Also, it might cause some pain. Around 40% of the patient might suffer pain from the infusion, and thrombophlebitis, which is a thrombosis in small blood vessels. It should not be used during pregnancy. And importantly, also, this agent interacts with the cytochrome 384. So we should again avoid or need to monitor the cyclosporin if a patient using the cyclosporin, or azole antifungal or to avoid the use of this combination. Thank you very much, and